Hello, and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Scott Olson, a pediatric infectious diseases specialist at Banner University Medical Center in Tucson, and an associate professor of pediatrics at the University of Arizona College of Medicine. Along with my colleague, Dr. Nathan Price, I'm the Arizona AAP Infectious Disease and Immunizations Co-Medical Director. If you're looking at the thumbnail of the podcast, Dr. Price is the stately one on the right, and I'm the one on the left. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of February 10th, 2025. Let's go ahead and jump right into the questions. Our first question this week, sent in by an AzAAP member, asks, right now, norovirus is causing widespread outbreaks. In your experience, what are the best strategies for preventing the spread of norovirus in pediatric settings? Before I get into prevention of norovirus disease, I think it's good to start with a basic summary of norovirus and its pathophysiology. So noroviruses are in the Calciviridae family. These viruses are single-stranded, positive-sense RNA viruses. And the noroviruses are particularly genetically diverse, and they can infect a wide array of host animals, including humans, dogs, pigs, mice, bats, and sea lions. Within the norovirus species, there are 10 different genogroups according to sequencing of the VP1 segment of the virus's capsid protein. And even though there are 10 different genotypes G1 and G2 are most prevalent in human disease, causing about 90% of infections. And more specifically, a subtype of the virus called G2.4 has been the most common cause of both sporadic disease and outbreaks of norovirus globally for the last 15 years. And unfortunately, with the number of different viruses that are out there, studies have shown that infection from one genotype doesn't appear to offer cross-protection against subsequent genotypes if exposed. And when you couple this with the fact that infection appears to induce a limited adaptive immunity, with estimates of waning as early as 24 months after infection, both of these facts add up to the reality that in the absence of an effective norovirus vaccine, patients can experience multiple episodes of norovirus illness over the course of their lifetime. And while in general norovirus doesn't tend to be the most life-threatening infection that we deal with, acute gastroenteritis is a massive worldwide problem, causing an estimated 685 million cases annually, resulting in an estimate of 1.5 million deaths per year. And while norovirus may not be the most severe of pathogens that results in acute gastroenteritis, I think we have to remember that among high-risk individuals, including young children, elderly, and immunocompromised patients, they can have severe complications of infection, including in developing countries, deaths from dehydration. With regards to transmission, norovirus is mainly transmitted by the fecal-oral route, and occasionally through contaminated food, water, or fomites. In particular, it's easily transmitted because of the small number of virions required for infection, with estimates as low as only 18 virions necessary to result in infection. Add to that the fact that infected individuals can shed billions of viral particles per gram of stool or vomit while infected, and that even after symptom resolution, transmission can occur, with studies showing positive testing by PCR several weeks after symptom resolution. It makes sense why norovirus in particular can explode so quickly within an enclosed population, such as schools, childcare centers, dormitories, military barracks, hospitals, and long-term care facilities. In temperate climates, transmission tends to occur year-round, with outbreaks concentrated during the winter months, which we've been seeing recently in the U.S. I think we're all pretty familiar with what norovirus looks like, but it's probably good to review just in case. Patients usually develop symptoms about 1 day after exposure to another sick individual, and then symptoms tend to last about 48 hours, with some mild symptoms lingering thereafter. The main symptoms you see in patients are nausea, vomiting, abdominal discomfort, diarrhea, and some patients may develop systemic symptoms such as fever, lethargy, weakness, and headaches. However, this is not universal for all patients. In young children less than 2 years old, one study found that 35% of children only experienced emesis with no diarrhea. So something to consider in patients of yours who are exposed and are younger. Unfortunately, there's no antiviral or FDA-approved therapies specifically for norovirus, so the mainstay of therapy is supportive care with focus on hydration status. Most patients can be managed on an outpatient basis. However, severe cases, particularly in young children, may require hospitalization for IV fluids due to ongoing losses from vomiting and diarrheal stools. Because there are no targeted therapies, prevention is really the key when we talk about norovirus. Unfortunately, as I alluded to earlier in my answer, there is no norovirus vaccine currently. However, there are several vaccine candidates under development that are undergoing preclinical trials. On a personal note, when I was in the U.S. Navy after finishing my ID fellowship, for about 2.5 years I was part of a group through the Naval Medical Research Center in conjunction with Takeda Pharmaceuticals looking at a vaccine candidate. Unfortunately, it didn't look like this vaccine really did what we were hoping, and vaccine efficacy was unimpressive. As I mentioned earlier, I think vaccine development is really hindered by the genetic diversity of the virus, the lack of cross-protection from other serotypes, the short-lived immune response, and our, frankly, incomplete understanding of how we develop natural immunity to norovirus infections. My hope is that we may have a better vaccine candidate sometime over the next several years, but unfortunately at this point I'm a little skeptical. So because of this, prevention of infection, like I said, is really critical. And so for the most part, we focus on hygiene measures. I think we're all aware that alcohol-based hand sanitizers are not effective to kill the virus on patients' hands. Therefore, focusing on good hand-washing techniques is really critical to try and mitigate spread of infection within the community. Particularly with younger children, it's really important to focus on washing for 20 seconds with soap and water, particularly after using the toilet, preparing or handling food, before eating, or after exposure to stool or vomitus if it's a school or other individual who's helping care for children. This is important because the virus can survive on hands for up to 4 hours. So in the absence of hand washing, a sick individual could really spread that virus around a group environment. In addition to hand hygiene, we recommend disinfecting surfaces with chlorine bleach-containing agents, which are best at killing the virus, or other EPA-registered disinfecting products that are noted to be effective against norovirus. If symptomatic, patients are recommended not to return to school, daycare, or work for about 48 hours after symptom resolution. And again, that's because we know that individuals can still shed and transmit in the period immediately after symptom resolution. If you'll allow me to add a little bit of a personal story here at the end of the question, several years ago, my family was all together over the holidays at my parents' home. My daughter, who was in daycare at the time, woke up in the middle of the night with some vomiting, and within 48 hours, 12 of the 13 people who were staying in the house were all sick with vomiting and diarrhea. So take it from me, do whatever you can to avoid acquiring norovirus this season, because trust me, it's not fun. I think that exhausts my answer on question 1, so let's go ahead and move on to question 2. Question 2 asks, we often encounter children with recurrent infections. When should we consider more advanced diagnostics like immunodeficiency screening? I have to admit that as a provider who does lots of inpatient consults on pretty sick kids, this is a question that I tend to grapple with every now and then as well. Now, this has been a bit of a moving target over the last several decades, and namely that's because of the prior high cost of laboratory workup for immune deficiency. Over the last decade or so, the cost related to these immune screens have dropped pretty significantly. So as a result, I think we are considering immune screening now in patients who 10 or 20 years ago, the cost-benefit analysis may have been a little bit different. There is some guidance from national groups with regards to which patients probably require immune screening. According to the American Academy of Asthma, Allergy, and Immunology, clinicians should consider immune screening if a child has persistent thrush after 1 year old, suggesting an underlying T-cell deficiency, requires IV antibiotics to clear infection, though that's a lot of kids, so I'm not sure that I necessarily fully agree with this recommendation. A child who has 2 or more deep-seated infections, such as deep skin structure infections or organ abscesses, or individuals with severe recurrent infections within a 12-month period. Now, depending on where you look, you may find a different definition of what constitutes recurrent severe infections, But the definition that I've used most often over my clinical practice is 8 episodes of otitis media, 2 episodes of sinusitis, 2 episodes of pneumonia, or has a family history of primary immunodeficiency. Additional clinical scenarios where immune screening should at least be considered include failure to thrive without an underlying etiology, or severe recurrent infections, defined as more than 2 episodes of infections such as pneumonia, meningitis, or sepsis. Then we get into clinical scenarios where it's not quite as cut and dry as to when immune screening is necessary. In these scenarios, I usually recommend to trainees that they think about which arm of the immune system would be affected based on the pattern of infections that they're seeing in their patient. So, for example, individuals who are experiencing severe sinopulmonary infections like otitis media, sinusitis, or pneumonia, particularly those that have failure to improve on oral antibiotics or presented with severe disease, there's a possibility that they have an underlying antibody or B-cell deficiency. Contrast that with children who present with failure to thrive, diarrhea, recurrent thrush, or opportunistic infections. That would suggest more of a T-cell deficiency, such as HIV. If you have a patient who is experiencing recurrent deep abscesses with organisms such as Staphylococcus, Pseudomonas, Aspergillus, or Serratia, which are catalase positive, this suggests a possible underlying oxidative burst defect in the patient's neutrophils or chronic granulomatous disease. Then the other one I think just to be aware of is individuals who present with recurrent episodes of Neisseria meningitidis infection, which should raise suspicion for a terminal complement deficiency. Now, I think this is all really useful to at least talk through and consider when you are approaching these types of patients, because the clinical concern is what's going to drive your decisions on which immune testing to send, or the immunologist if you were going to refer your patient onward. So when you're just thinking about what tests are useful to do an immune screen on your patients, I think the most useful ones as first line include basic blood count, or CBC with differential, lymphocyte subsets to make sure that though the lymphocyte count may be normal overall, you're also having normal levels of CD4, CD8, and K cells. Quantitative immune globulins to make sure you're not having a hypogammaglobulinemia or other B-cell defect. And finally, complement levels with CH50, which looks at the overall complement level, and AH50, which is a little more specific to the terminal complement levels. And finally, antibody levels against immunization can be useful to make sure that those patients with normal absolute values of their immune globulins are actually having normal function and can target antigens with which they are challenged. Commonly, we'll send tetanus or diphtheria antibodies to assess for a patient's ability to mount a response to protein antigens, and to assess a patient's response to polysaccharide antigens. You can send Streptococcus pneumoniae antibody levels both before and after administering PPS-23, which is the polysaccharide vaccine against pneumococcus, to assure that after challenge with a polysaccharide antigen, the patient's able to develop a robust immune response. Similarly, patients' T cells can be isolated and stimulated in vitro with different mitogen assays to assess for normal T cell function. However, this type of testing, as well as antibody testing following PPS-23 receipt, tends to be something that's done more often in immunologist offices because the results can be a little tricky to interpret if you don't have familiarity. I also want to remind clinicians that in addition to these immune-specific tests, there are a number of other routine tests that can be useful when you're considering a patient's immune status. So, for example, reviewing the patient's blood spot from infancy can be really useful to make sure that both the cystic fibrosis testing and severe combined immunodeficiency, or SCID testing, was normal at birth. Additionally, as I've alluded to already, the most common cause of an isolated T cell deficiency is human immunodeficiency virus, or HIV infection. So remember that we often pair our immune screening with an HIV screen, regardless of the patient's risk status. And finally, there is now genetic testing panels that are available for evaluation for specific immunodeficiencies with known genetic causes. But I'll be honest, I don't tend to order or manage that testing. So really, if you're at that point, you should be referring your patients onto immunology. Now that we've gone through all that, I think it's really important to remind people that children, particularly in the first year of group care, will experience a significant number of illnesses, namely because it's their first exposure during their lifetime to what will be common viral illnesses with subsequent seasons. There are estimates from several different epidemiologic studies suggesting that children will experience about 7 to 10 illnesses in the first year of group care. And because most of these are the result of respiratory viruses, those illnesses tend to cluster in the fall or winter months, so children can experience back-to-back illnesses that otherwise could appear to be just one prolonged illness. For me, what's really useful to distinguish between these two scenarios is to focus on a few historic aspects to the patient's presentation. So, for example, I like to ask about the patient's birth history and particularly maternal prenatal course and whether or not the mom was tested for things like HIV, trying to see whether or not I can find the infant's blood spot to make sure that SCID and CF testing was normal, talking to the family a little bit more about the specifics of the patient's infection history, so getting into what number and what types of infections they've experienced, how many antibiotic courses they've required, how many of those required hospitalization or intravenous administration, and whether or not they've experienced infections with illnesses that are otherwise vaccine preventable despite immunization. Additionally, going into the family history to ask whether or not there are family members with severe recurrent infections, early childhood deaths, or any known immune issues. And then also looking at the patient's immune status, really just to confirm that if they are experiencing vaccine-preventable illnesses, that they actually received the vaccine in the first place. And I think I'll just finish this question by saying that while I feel fairly comfortable assessing whether or not a patient needs immune screening, I am just a humble, lowly infectious disease doctor. So when in doubt, go ahead and refer on to your friendly neighborhood immunologist. I sure know I do. I think I've exhausted that question, so let's go ahead and move on to question 3, our final question of the week. Our final question of this week comes from an AzAAP member who asks, what role does hygiene education play in preventing infectious diseases in children, particularly in a school daycare setting? How can we make this a more important part of preventative care in our practices? Since we're all pediatric providers, I'm going to assume that we are all in agreement that respiratory hygiene does play an important role in mitigating transmission of infections within the community. Because these efforts involve a number of different interventions, it can be a little difficult to identify which of them specifically goes the furthest in preventing infections, but I think we all understand after going through COVID that it takes a number of different interventions to really provide that protection. When we talk about the interventions that we can counsel families on to really improve their practices outside of our clinic, it's mostly going to focus on things like appropriate hand hygiene and appropriate respiratory etiquette, such as covering mouth or nose when coughing or sneezing, and preferably wearing a mask if symptomatic. But there are also other things that we can encourage families to consider when we're going into respiratory season. So, for example, strongly promoting and encouraging immunization against respiratory viruses where we have immunizations is really important. Additionally, I think it's reasonable to tell the families they should be conscious of what sort of mitigation efforts schools that their children attend are performing, and then providing them some of that information so that they can be their child's advocate when dealing with school administration, which I think is particularly important when you're dealing with high-risk or immunocompromised patients. And while these interventions are difficult to study because of their multifactorial approach and because they oftentimes need to be observed in a messy real-world setting, there are actually some good studies out there that I think support a lot of these efforts. So, for example, this is a little bit of an older study, but back in 2011, there was a study in the Pediatric Infectious Disease Journal that demonstrated in a randomized controlled trial in the Pittsburgh area the respiratory hygiene education and regular use of hand sanitizer significantly reduced laboratory-confirmed influenza A infections by over 50%, and also absenteeism by about 26%. when it comes to the specific question of masking, though this isn't necessarily related to schools, there was a good study published in MMWR back in 2022 that came out of California demonstrating that among individuals who had been in enclosed indoor public settings, those who had been masking had a decreased likelihood of testing positive for COVID-19 compared to those who didn't mask, with cloth masks demonstrating a 56% reduction in odds of infection, surgical masks 66% reduction in odds, and a respirator, either N95 or KN95, associated with an 83% reduction in odds of infection. And more recently, in 2024, there was a study published in the Public Health Journal that demonstrated, in a systematic review and meta-analysis, that multiple or specific combinations of interventions, such as respiratory hygiene, were associated with lower secondary attack rates of COVID in school settings. And the final study I'd like to highlight was a case control study from Spain that was published in BMC Public Health back in 2015, which showed that frequent hand washing was significantly protective against influenza infection in school-aged children. So going back to the original question, when the writer asked, what can we do as pediatricians? I think it really comes down to counseling and educating families and making this a routine practice, particularly as we head into respiratory viral season. And I think that's where I'm going to leave it with this question, but certainly if there are any follow-up questions or points of clarification listeners have, please feel free to email in, and I'm happy to get to those questions with our next podcast. Thank you again for listening. Remember, AzAAP members can submit questions for future episodes to id@azaap.org. The AzAAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant Funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, visit azaap.org. As always, thank you for these interesting consults, and we'll see you next time on ID Talk.